Hi everyone, it's Jason here, and for this next video we're going to be digging a bit deeper into mood disorders. So if we're looking at mood disorders, we need to think about the way that we describe feelings, and there are two main ways that we do this. We can talk about a mood, which is a kind of sustained and pervasive emotional attitude, which is going to color your whole life, versus an emotion, which is a short-lived emotional response. We often call it affect in psychology. So that's kind of a reaction to a particular idea or event, whereas a mood is something that is more pervasive and lasts longer. We can experience moods and emotions at the same time, but emotions seem to kind of sit on top of moods. So, for instance, when you're in a bad mood, it's quite possible to have brief feelings of happiness and joy, or someone might be able to make you laugh. And similarly, when you're in a good mood, it's still possible to have moments where you might feel sad or angry about something. So the mood is kind of sitting underneath, and occasionally different emotions can kind of pop up on top. We're looking today at mood disorders, and a big part of mood disorders is something that we call a manic episode. People might have heard this term before, and I'll dig into what that means. When somebody's experiencing a manic episode, these are some of the characteristics that we'll see. Usually, if they're in a manic episode, they have this really kind of elevated mood. They've got an inflated self-esteem. Often they will sleep less and they have these kind of racing thoughts. They might have difficulty maintaining attention and kind of be flitting from thing to thing. Often we'll see psychomotor activity like fidgeting or kind of restlessness, increased energy levels. Often there's changes in their speech and their thought, so they might use some kind of unusual words or kind of delusional ideas. Often they're really goal-directed. They're trying to achieve a huge amount in a short space of time. And when they're going through this kind of episode, there's usually an absence of any kind of underlying organic cause. It's not like they've taken a drug that is doing this. And for it to be diagnosed as a manic episode, it has to have lasted for at least a week. Often these can go on for months, but it has to have lasted at least a week, and it's obviously going to be causing disruption to their daily activities. So that's a bit of a picture of what a manic episode looks like. When a person's in this, they feel on top of the world. They have no insight into the fact that they're experiencing a kind of mental health crisis. For them, they're feeling great. They've never had so much energy. They've never felt so alive. These manic episodes can kind of happen in 4 different stages. And you'll see there what we call euphoria, which is a kind of mild elevation of their mood. The person feels really happy. Next level is elation, which is there's that real kind of sense of self-confidence and enjoyment, and they might be more kind of agitated and active. Then we've got exaltation, which is really intense elation, severe kind of elevation of mood, often with delusions of grandeur. So the person might be convinced that they're in some way more important than they actually are, or that they would usually be. They might think that maybe they've been selected for some kind of secret mission, or that they were given a special purpose from God or something like that. So the delusion part of it sneaks in there. At the very top, we've got ecstasy, and this is intense feelings of rapture or blissfulness, and often completely divorced from reality. So this is similar to a psychotic episode, and that's something we'll discuss when we talk about schizophrenia. But this ecstasy is severe mania. So we kind of have 2 main categories here. We've got hypomania and mania. Hypo, you might know that prefix. It means under or lower. So if someone is experiencing hypothermia, then they're experiencing low temperature. So the hypo kind of means low. So we've got low mania, where the person's maybe got increased energy levels and increased confidence, and they're really working hard, getting A's, achieving goals. And then we've got full-blown mania, where the person literally thinks that they can fly. They're on a totally different plane and usually kind of quite divorced from reality. So a little bit more detail on some of these symptoms, and I won't read everything on these, but if you want to take some notes, feel free to pause the video. When it comes to speech and thought, the person is more talkative. Their thoughts are really racing. They often are joking and teasing more than normal. They speak really loudly. They have, like I said, those delusions of grandeur. And all of those features kind of match the elevated mood, and they're called mood congruent psychotic features because they're all kind of in line with that elevated mood. Some of these, though, are not in line with that elevated mood. So delusions of persecution or hallucinations might be mood incongruent psychotic features, where those delusions and hallucinations are upsetting rather than elevating, if that makes sense. The goal-directed activity, usually when the person is manic, they're unusually alert and they're trying to do lots of things at the same time. With hypomania, usually it increases the person's ability to function. There's an increase in their productivity and their creativity and that kind of stuff. When it moves into mania, that's often lost. When it's mania, there's a really big increase in activity, but sometimes with excessive planning and distractions and that kind of stuff, sociability goes up, talking with previously unknown people, poor judgment, risk-taking behaviors. Often people that are having a manic episode will drive recklessly or act promiscuously or give money or spend money in crazy, reckless ways. So they're kind of not functioning as effectively. Other features we mentioned were things like decreased need for sleep. Often they'll increase their appetite, but then they get so overactive that they stop intaking enough food. And a really key feature of any manic episode is a lack of insight into the illness. The person experiencing it doesn't think that there's a problem, and in fact, they might be feeling better than they ever have. So at the total opposite end of the spectrum, we have a depressive episode, and this is where we start to get into the whole idea of mood disorders. Depression, most of you guys will know already, is characterized by things like depressed mood, depressive thoughts, restlessness, often fatigue, loss of interest in activities, and we call that anhedonia, when the person loses interest in activities that they used to enjoy. Sometimes they might have thoughts of taking their own life, and there doesn't seem to be any other underlying organic cause. There's not an obvious tumor or issue in the brain or anything like that. For diagnosable depression, it has to have been lasting for at least a couple of weeks. So the depressed mood can take a whole bunch of different forms. Sadness of mood, loss of interest or pleasure in almost all activities. Like I said, we call this anhedonia. So there's this pervasive sadness, and it's present throughout the day and over a long period of time. So it's kind of persistent sadness as well. It might vary from day to day, but the point is that it continues on over a long period of time, and it's often unresponsive to environmental stimuli. That means even if good things or bad things are happening in your life, it doesn't seem to change that underlying feeling of sadness. Often there's social withdrawal, and that's obviously a big alarm bell if you notice that in somebody that you know. And there's a decreased ability to function in daily life, occupational, social areas of life. When somebody's experiencing a bout of depression, and we've all been through this to some degree, whether it might be small or large for a short time or a long time, these are symptoms that we all kind of have at different points in our life. And we all often, when we're in this state of mind, we have three common types of depressive ideas. The first one is hopelessness. This is where we figure that there's no way that our situation is going to improve or that we're going to feel better. Helplessness is that there's no other option. Nobody could help us even if they wanted to. And the worthlessness is about the self-esteem, that we're not good enough anyway. We're not deserving of people's help and that we don't deserve for life to go better. So we often fall into those three kind of traps of negative depressive thinking when we're feeling this way. Some other features when we're feeling in this kind of state of mind are things like difficulty concentrating and slowed thinking and bad memory. A big thing and a very serious thing is suicidal ideation. So that's when somebody is thinking about suicide, and this should always be taken seriously. Some of the factors that can increase the risk and some of the things that might be a bit of an alarm bell if you notice any of these things in a friend or family member: a marked sense of hopelessness. If the person starts talking like there's no hope, or that things will never change, or that they feel like life is never going to get better, that they'll never be able to shake this feeling, that's a big sign. Obviously, if there's any written or verbal communication of an intention to take their own life or a plan to do so, when I was working in some kind of counselling roles, that was always one of the first things that we would ask is, have you made a plan? And that does seem like a really confronting personal question, but it's a genuine attempt at understanding how much this person needs support. The other big thing to look out for is really sudden or uncharacteristic recovery from depressive symptoms. Often when somebody does decide to take their own life, they almost feel a sense of relief that they've solved the problem. We know obviously that that's not the way to solve the problem, and there's always other ways to get help. But often the person will suddenly change their behavior, and they don't seem to be behaving the way that they were. They seem like they're fine, or that there's been a weight lifted from their shoulders. If that happens very suddenly, that can also be a real alarm bell that maybe the person has made a plan to do something like this. So please, if that's ever something that pops up in your life, make sure you seek support for yourself or for others that you might come across. So we've got these disorders that stem out of these depressive symptoms. The most common one is what we just call depression, or actual major depression, or clinical depression. And that's when somebody's experiencing these symptoms for most days, like I said, for at least a couple of weeks. And the symptoms are interfering with all areas of the person's life. We do have some other forms of depressive disorders, though, things like postnatal depression, which is experienced by mothers in the year following childbirth. And that seems to be linked to a whole bunch of things to do with women's bodies and the way that they adjust, obviously, to a very different life and a very different body after birth. Dysthymic disorder, or dysthymia, which is similar to major depression but kind of less severe and longer lasting. So the symptoms go on in a milder fashion, but for 2 years or more. And then we've got seasonal affective disorder, which is about the different seasons and how they affect people's mood. So it's thought to be related to the variation in light exposure and that kind of thing. And the idea is that the person experiences either depression or sometimes mania that seems to begin and end in a particular season. Most commonly, it's depression that starts in winter and then kind of goes away as the season ends. It's pretty rare in Australia, but in Scandinavian countries, for example, where winter there's only sunlight for a few hours a day, that sort of thing is a more common problem. So then we arrive at bipolar disorder, which combines these states of mania and depression. In fact, this used to be called manic depression. That's a term that's not used anymore. It's called bipolar disorder, and it's characterized by recurrent episodes of mania and depression in the same patient, but at different times. So they'll go through a manic phase or a manic episode, and that will be followed by a depressive episode. There are a couple of subtypes here, and I've kind of scaled these on this slide. So bipolar type 1 is potentially the most severe because the person has severe mania. That's the one where you've completely lost touch with reality, and severe or major depression. Bipolar type 2 is that hypomania. So the person might have the elevated mood and energy levels and that kind of stuff, but it's not full-blown mania. But they do also experience very severe depressive episodes. And then a step down from those two, I guess, is what we call cyclothymia or cyclothymic disorder. And these are periods of kind of symptoms of hypomania and periods of symptoms of depression, but those symptoms are not quite sufficient enough to be called straight bipolar type 2. So they're not fully hypomanic episodes or fully major depressive episodes. So if one of these things is going to be diagnosed, they have to kind of rule out a certain number of things. They've got to make sure that It's not a result of normal environmental triggers like somebody going through intense grief. It's not because of any organic causes like a drug-induced manic episode or psychotic episode. They've got to rule out psychotic disorders themselves like schizophrenia and schizoaffective disorder and a few of those things. We'll talk more about those disorders later on. And they've also got to look out for other potential comorbidities. Does the person already experience problems with generalized anxiety or obsessive compulsive disorder? Do they have a substance abuse issue or any other underlying kind of pre-existing condition? This has come from the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, and it's just got a little description here of how we might separate bipolar 1, bipolar 2, and cyclothymic disorder. So you can pause there if you'd like to look at that in more detail. So how do we treat these conditions? Well, with depression especially, the most common treatment is with an antidepressant. And that's pretty much the drug of choice for the vast majority of depressive episodes. Most antidepressants take up to about 3 weeks for the therapeutic effect, and they say you should be taking them for at least 6 weeks before you stop or change or decide that it's not working for you. Like most drugs, there are a lot of side effects, potential side effects, and one of those that almost pops up every time is nausea, but also things like weight gain, lower sex drive, tiredness and trouble sleeping, and constipation, dizziness, various other bits and pieces. Also, from that kind of biological perspective, we've got lithium. You may have heard of lithium, and it's one of the most widely used medications for treating bipolar disorder in particular, because it seems to help reduce the severity and the frequency of mania. It can also help relieve depression and seems to significantly reduce suicide risk in about a third of patients that it works for. But again, it can have quite significant side effects. Nausea again, diarrhea, dizziness, issues with heart palpitations and muscle weakness and various things. One of the other common biomedical treatments that most people think doesn't exist anymore, but it's still very much an option, is electroconvulsive therapy. And this involves passing a controlled electric current through the brain, which affects the brain's activity and kind of relieves depressive and psychotic symptoms. Scientists still don't know exactly how it works, but it seems to work as a bit of a reset button for the brain. Modern-day electroconvulsive therapy is very different to what you might have seen in the movies or heard about, and there's a lot of stigma around this treatment. But these days it's very controlled, it's very safe, and it's usually quite effective in patients with severe major depression. So it's usually only used in those cases where there's really severe depression with a risk of suicide, where there's severe depression with stupor or psychomotor retardation, meaning that the person is unable to use their body or move their body in the same way. Delusional depression, where the person seems to be experiencing delusions along with the depressive symptoms. And then obviously cases where significant antidepressant side effects have been seen. So if the antidepressant drugs are really knocking someone around and just not helping at all because the side effects are so severe, they might try ECT as another option. And it's usually administered 3 times a week for about 4 weeks, depending on the patient and their needs. And then we've got, from the kind of talk therapy side of things, a whole range of different therapeutic approaches. So biological, medical stuff we've talked about, and then here we've got things like CBT, which you've probably heard of before, cognitive behavior therapy, which is very much that cognitive perspective. Let's talk about the thoughts going through your mind when you're experiencing a mental health crisis. How can we help you reframe those thoughts and engage in more effective strategies or behaviors in order to help you feel better? From that real humanist kind of perspective, we've got interpersonal group therapy. Those are sessions where people with common issues, so maybe a bipolar support group where people share their stories, and through that group interpersonal interaction, develop a bit more understanding of their condition. They feel less alone, and they feel like they can get ideas and strategies from other people going through the same kind of thing. From the psychoanalytic perspective, we've got psychoanalysis, which is that idea of kind of digging into a person's unconscious or subconscious, what happened maybe during their childhood or their formative years that's affected the way that they view the world now and the way that they're behaving, and how could we understand their current illness by understanding their past. And then from a really pure kind of behaviorist perspective, we've got behavior therapy, which is very much about conditioning new different behaviors as a way of trying to manage the more challenging behaviors. So hopefully you get a really good picture here of depressive disorders, of bipolar disorders, of the key characteristics of a manic episode and a depressive episode, and some of the key treatments for those symptoms. If you're looking to dig into a little bit more detail, Crash Course Psychology on YouTube has an episode on depressive and bipolar disorders you might want to check out. And then just make sure you do your Psych 5 this week. Check out this video and the other video. Do your activity sheet. I'll see you in the video conference, and then you've got your little quiz at the end of the week. Thanks for listening, everyone, and I'll chat to you soon. Bye.